continue on. So we've got just a few topics left to clean up. So I want to mention just briefly something called juvenile rheumatoid arthritis. So juvenile rheumatoid arthritis is also sometimes called juvenile idiopathic, which tells you something about it. Arthritis. So the abbreviation is JRA or JIA. These are different ways you can see it or read about it. So again, it's going to be inflammation and pain that goes, more longer than 6 weeks in a joint in somebody under the age of 16. So it's under 16 years. So pain, inflammation that lasts longer than 6 weeks in the joint. It's autoimmune, which is why it's referred to as a rheumatoid arthritis. Redness and heat and swelling often is a single joint, which makes it different than regular rheumatoid arthritis. But it can be polyarticular, it can affect more than one joint. But it will also often include inflammation of some internal organs, like the heart or the liver or the spleen. It's episodic, it often subsides all on its own. About half of those, and they're more often females than they are males, will recover with no signs or symptoms or leftovers, no sequela whatsoever. Treatment during the flare-ups is similar to rheumatoid arthritis, but because they're often younger individuals, there's a little more emphasis on exercise and lifestyle adjustments and a little less emphasis on the medications. Because with the growing bones and the growing tissues, the intervention of those disease-modifying medications can be pretty dramatic to the tissues. So it's typically single joint, but autoimmune. So that's why it's related. More than half recover. Just trying to write down some of the highlights here. Recover with no sequelae. Rarely involves inflammation of organs like the heart or the liver. And sometimes some other ones. So those are some of the things to be aware of with respect to juvenile arthritis, because you'll see that when you're covering the topic of rheumatoid. Now, a couple other ones we'll just mention very briefly. They're common enough. You'll see them in clinic. Ankylosing spondylitis. This one's interesting because almost all, with the exception of osteoarthritis, are more frequently diagnosed and identified in females. But ankylosing spondylitis, spondylo tells you it has something to do with the spine. Ankylosing is a fancy word for fusing. So this is one of the few arthritides or arthritic conditions where it's more common in males than it is in females. And it's a little bit of a younger onset than what we typically see, with the exception of juvenile rheumatoid. But probably somewhere in the ages of 15 to 25 years old. For the onset in someone. And the sort of cardinal presentation for somebody with ankylosing spondylitis is that they have a progressive fusion of the joints in the spine, especially beginning at the sacroiliac joints. So the sacrum, remember, was 5 fused vertebrae at the base of the spine. And then you have your lumbar vertebrae. And the sacroiliac joints were the joints between the sacrum and the bones of the pelvis. So when we're talking about this progressive fusion that begins down to the SI joints, what literally will happen is that the sacroiliac joints will begin to fuse. They'll lock up. Now, they don't have a lot of range of motion anyways, but they will start to affect, like, for example, the length of your stride. You can appreciate that the sacroiliac joints move in the opposite direction. When your right leg goes forward, the sacroiliac joint rotates on the right side forward and on the left side backward, and vice versa when you step forward with your left leg. So there's this give and take, right? It's going in the opposite directions. If those joints start to fuse, then the length of your stride will be reduced, both going forward and going backward, because those joints don't move through the full range of motion. So your stride shortens. You start to walk with a bit more of a shuffle. And then as the as the progression occurs and it starts to involve the joints of the spine, then you start to see fusion between the sacrum and the lumbar 5, and then lumbar 5 and 4 and 4 and 3, and so on. And it starts to fuse progressively up the spine. And it'll look, there's a nicer picture of this. Okay. So in this picture, when we look at this picture here, we're looking at a normal spine, and everything's nice and clean. That's all you want to look at in this picture. Nice and clean, everything's neat and tidy. And here you can see the fusion. There's some loss of joint space, there's immobility between those joints, and the joints are going to start to encroach. They can encroach on the nerves. That's what those things are that are coming out of there, and start to create some nerve irritation and so on. But the immobility is the big thing. And as the fusion progresses up the spine is going to rotate. So these patients start to have a decided lean forward. And you can really appreciate that they develop this severe kyphosis, which is that forward angle concave anteriorly of the majority of the spine. And as a result of the spine kind of leaning forward like this, that in order for them to see effectively, they have to tilt their heads up in an awkward position. So they're walking, leaning way forward like that. So it creates these distortions in the vertebrae, in the angles, in order to be able to walk and be able to visualize your environment. You're severely impacted as far as that goes. So let's go back to that screen. So with ankylosing spondylitis, we get this progressive fusion starting at the sacroiliac joints and progressing superior. So they'll involve the lumbar spine and the thoracic spine if it's not interrupted. So there is a genetic predisposition to this. So it's not a hard genetic lineage, but there is a predisposition. So it's seen in families a little bit. Combined with some environmental factors, not all of which are understood. But it is an immune-mediated inflammation that causes back pain and decreases mobility and promotes fusion. So it's another one that's very slow to develop. Often the patients aren't going to be aware at all that they're reduced in their stride length and then maybe a little stiff in the back. But one of the things that's a bit distinctive is that the pain is notable at night. So when they're not weight bearing, this is a little indicator, a little thing to look for and ask the right questions during a history taking. So pain at night is a little bit classic for this as far as that goes. Now you have to differentiate, because another one that is notorious for creating pain at night is cancer, bone cancers. So you have to differentiate between something a lot more ominous, bone cancer, than what this is as far as that goes. The big difference, the big advantage is that this improved with exercise. So the more mobile, in fact, if you look at old textbooks, they always say gymnastics is the best treatment for somebody with ankylosing spondylitis. And in old textbooks, when they say gymnastics, they don't mean the sport gymnastics. They mean, they do mean things like tumbling but it's all about large range of motion exercises is what they're referring to. So what you're trying to avoid with the exercise is that gradual forward flex posture that's going to require bracing and exercises that counter that tendency to want to flex forward progressively. Because if the thoracic spine is allowed to progress too far forward, then it starts to interfere with your chest expansion. Your lungs can't expand as effectively. If they can't expand as effectively, you're more prone to lung infections because you're losing some of your natural immune defenses just with not being able to breathe as effectively as you can when you're otherwise healthy. So the treatment is pretty much treating the symptoms for pain and inflammation, and the exercise. Big range of motion exercises is the focus for these people, big time. Now, another form of arthritis that is clinically reasonably common, you're going to see it if you haven't already, is the arthritis associated with systemic lupus. SLE is the abbreviation. So the thing about lupus is that it's chronic. Basically, all of our arthritis is chronic. It's multi-systemic. That's where the systemic in the name comes from. Multi-systemic. And this is another autoimmune condition. So females more than males, just like rheumatoid arthritis and juvenile rheumatoid arthritis. It is a relatively early onset. So females more than males. Onset is in your probably late teens to 40s for onset, which may coincide with increased levels of estrogen, cycling estrogen and progesterone. There's some thoughts that it's got an endocrine component to it. It's triggered by what are so far unidentified environmental factors. But what we know is it's an abnormal immune reaction against ourselves. So it's an autoimmune reaction. And it's a B cell abnormality. So it's auto antibodies are being produced that target many different tissues in the body. They target the heart, they target the kidneys, they target the skin, the nervous system, the lungs, and the digestive system. This is why it's referred to as a systemic presentation. And what happens in the joints, which is why it becomes an arthritis. So these autoantibodies bind to targets in these various tissue types and create inflammation and irritation and dysfunction. It can be very disabling. It is a little bit cyclic or with those exacerbations and remissions. And the treatments are going to be with our anti-inflammatories and corticosteroids, as well as our immune suppression medications. So those are the arthritic conditions. And the last topic that we want to talk about is osteoporosis. Osteoporosis clinically is very, very common. Osteoporosis, I got a picture of that too. There's a nice fancy picture of osteoporosis. So the picture on our the picture on here is showing dense, healthy bone. Okay, and the idea when you look at the picture to the left of that, you can see that there's large spaces. There's large areas where we've lost some bone mass. So osteoporosis is the most common metabolic but preventable bone abnormality. More than 1 million Canadians are living with osteoporosis as we speak. And it's responsible for about 150,000 fractures per year in Canada. So this is the most common preventable bone pathology. Responsible for more than 150,000 fractures a year in Canada. So that's huge when you think about it. And it probably is an even bigger number, because a lot of times what happens is someone is living alone at home or, maybe with their family, but they trip and they fall. And when they fall, they break their hip. And more what we're recognizing is that these are people with osteoporosis, and we think that the landing from the fall is what caused their hip fracture. But the reality is, in some of these cases, this bone over here has become so thin and so fragile that a little twist or a little stub of the toe can actually cause the fracture to occur. So they fell because of the fracture. They didn't cause a fracture because of a fall. Fracture was first in a lot of these cases. So the big issue with osteoporosis is that it's responsible for what are called pathological fractures. In other words, they're not fractures that would happen because of a trauma, but because of an underlying pathology. So we know, because we started at the beginning of today talking a little bit about it, that normal bone growth and maintenance is a balance between osteoblasts and osteoclasts. And that balance is what's responsible for our bone density. So as we get older, that becomes out of balance with age and sedentary lifestyle. It seems that the clasts start to outperform the blasts. So we get an abnormal balance. So it becomes unbalanced. And as a result, what we see the most dramatic loss in is that trabecular bone. We do lose some of the cortical bone, the solid looking bone, but the greatest loss is in that trabecular bone. And if you remember, trabecular bone was sort of that network of struts, of supports, especially at the ends of joints, ends of long bones associated with joints, because those struts, those thin bars of bone, made the bone lighter, but also able to absorb forces more effectively. So when we lose that trabecular bone, that spongy bone, we lose some of our ability to absorb forces effectively. So basically what's happening is that we have a decrease in the trabecular sometimes known as spongy bone, more so than the cortical bone, which was also known as dense bone. You might remember dense and spongy. So if we have a bone, you know, you saw the picture, but basically a normal healthy bone might show with cortical bone on the outside. So that I'm just going to put a line across there. And if we go to the next. So if we drew this bone this way, then all the cortical bone would be that, what we see right there. So the cortical bone gives the whole bone the sense that it's solid. But we know in reality, it's not. So up in that is a long bone. We've got our red bone marrow. And then what we have is the formation of these bars of bone, the trabecular bone. And in nice healthy bone, this network of trabeculae forms a very strongly branched and arranged set of supports that give that joint the ability to transmit forces from one joint surface to the next joint surface and the next bone. So what's going to happen in somebody with rheumatoid, with osteoporosis, is they start to lose the trabecular bone much more aggressively than they do the cortical bone. At the same time, they're losing some of that as well. So the trabecular bone starts to lose some of its integrity, and the bone gets thinner and thinner and thinner. So that's when we say that we lose the trabecular bone much quicker than we lose the cortical. But in order for it to become even visible on X-ray, we have to lose more than 30% before it shows. On a standard X-ray. And we have to lose probably more than 50% before it becomes symptomatic. So by that time, it's too far. It's too far gone. You're not going to be able to fix things at 50% loss. And often, first indicator is what they call a spontaneous fracture. And it's not truly spontaneous, but because there were no symptoms ahead of time, it seemed to be spontaneous, came out of nowhere. But it's not truly spontaneous because of the osteoporosis, but it wasn't identified before that happened. So that's where the terminology comes from there. So we don't really understand exactly why osteoporosis develops, except that probably to some degree, it's a part of the natural aging process of the skeletal system, particularly in association with the fact that as a lot of people age, they become less active. Less activity on the skeletal system means less stressors, and less response to the stressors means less bone mass. So we know risk factors include age, okay, and specifically an increase in age. And so the osteoporosis is more likely to occur the older you get. It's probably got a prevalence in the neighborhood of 15% at age 50, and that increases to more like 70% at age 70. So there's a big difference between those 20 years or so. There's a little bit of family history. So those are two things we don't have a lot of control over. But estrogen levels are implicated. So what happens around the age of 50 in most women is estrogen levels drop off significantly. So we decrease the estrogen, and that sort of takes the brakes off of osteoclasts. So there's a little bit of a relationship there between the hormone estrogen and osteoclast activity. We know that there's an increase. There's a decrease in total bone mass in Caucasians and Asians generally. So that puts you at a disadvantage. And we'll talk about what we're talking about with that bone mass in just a second. But basically, that's a big factor. We know that females are more at risk than males. We know that if you've got a dietary deficiency of calcium and or vitamin D, that puts you at risk. If you're sedentary, that's a risk factor. This one won't surprise anybody. Smoking is a risk factor. Alcohol is a risk factor. Neither one of those will probably surprise anybody. Kidney disease. Basically, what we're talking about there is the same thing as calcium and vitamin D deficiencies, because if the kidneys don't work properly, they're not going to reabsorb calcium effectively. That's supposed to be a line through there. So you got abnormal filtration, corticosteroid therapy. Is a risk factor. We know all about that with when we talked about the stress response and all that sort of thing. So basically, what makes it preventable is your starting bone mass. In men is greater, which explains why men are less at risk for osteoporosis. Their starting mass is greater. And in women, other than Caucasians and Asians, they start generally with a better peak bone mass to begin with. So you reach your peak bone mass at plus or minus 30 years of age. So if the more physically active you are, the stronger your muscles are, the bigger your bone mass is going to be. Now, the exercise has to be weight-bearing exercise. This is an example where cycling and swimming are great cardiovascular exercises, and they're great exercises for range of motion, but they are not helpful for osteoporosis. Osteoporosis has to be weight-bearing because that's the type of exercise that will stimulate bone growth. Years ago, they thought that osteoporosis was a given. You couldn't reverse it, but we know that if we supplement with calcium and vitamin D, and we know that if we become physically active, even past peak bone mass, you can slow down the progression of osteoporosis. So the disease of osteoporosis is where, it's sometimes described as disuse osteoporosis. Bone growth responds to stresses, especially weight-bearing stresses. Those stresses will stimulate the osteoblasts. And that's what we're trying to do as a correction. So people that are also at risk maybe if they have low vitamin C, if they have low protein in their diet, those would be factors that would play a role as well. People who are hyperthyroid are prone to and people that are hypercortisolism, Cushing's disease that we talked about, Cushing's syndrome that we talked about last week, would also be at risk. So the key thing that's making it preventable is establishing your peak bone mass. And you guys at your age have a great opportunity. Some of you still have 10 or 12 years before you reach peak. And peak is plus or minus 30. For some people, it might be 35 or 40 even, as far as that goes. So, so you still have lots of opportunity to establish a peak bone mass and prevent osteoporosis ever being a concern for you.